about how to overcome resistance in immune checkpoint therapy in GU malignancies. But really, I'm just using GU cancers as an example. So these principles are pretty general. So following the spirit of the meeting, so I will just um, discuss a couple of my data slides and then leave some time for discussion. So I don't have to talk too much about the background of immune checkpoint therapy, but as you know, for the past several years, GU cancers have been very fortunate to have so many drugs approved by the FDA, especially for bladder cancer. So the first drug, actually, immune checkpoint therapy drug tested in bladder cancer was actually anti-CTLA-4 or ipilimumab, which was done by Pam Sharma over 12 years ago. But it was done in a pre-surgical setting only in 12 patients. 3 patients actually had a response at that time. So after that, many years after that, so we have 5 drugs, 3 anti-PD-L1 antibodies, including atezolizumab, durvalumab, and evolumab, plus 2 anti-PD-1 antibodies, nivolumab and pembrolizumab, all approved by the FDA within about a year of time as either first-line or second-line therapy for bladder cancer. For kidney cancer, now we have 2 agents, nivolumab as a second-line therapy, and also nivolumab plus ipilimumab as a first-line therapy. But as you can tell, the response rate for all these agents, pretty much for monotherapy is pretty much from 15 to 25%. Even for combination therapy, the response rate was 42%, and which is associated with grade 3 to 4 toxicity in 46% of the patients. For prostate cancer, we have not been so lucky. So far, there is no immune checkpoint therapy has been shown to be beneficial for prostate cancer. For example, anti-PD-1 or nivolumab has been tested in a small phase 1 trial in 17 patients. None of them actually responded. Ipilimumab has been tested in a small phase 2 study of 27 patients by Anna Aparicio at MD Anderson. Again, only 1 out of 27 patients actually showed response. And after that, ipilimumab has been tested in 2 phase 3 clinical trials, and neither showed any clinical survival benefit. So really, this brings up 3 fundamental questions. One is, what are the resistance mechanisms for immune checkpoint therapy? 2 is, how to overcome these resistance mechanisms? And the third question, of course, is, what's the mechanisms for for toxicity for immune checkpoint therapy? Of course, for today, I'm going to only focus on the first 2 questions. So whenever we face a very difficult problem, I think the approach to solve the problem should be very simple. So we really took a very simplified approach to look for resistance mechanisms. So I think the resistance mechanism should be either inside the tumor or outside of the tumor, or in the tumor microenvironment. So to look for resistance mechanisms in the tumor, we actually use melanoma as a model. So we studied a total of 16 melanoma patients treated with nivolumab. Among them, 4 patients actually had response. The other 12 patients didn't respond. So when we look at the exome sequencing profile, we found in the 4 responders, none of them actually had any defect of interferon gamma pathway genes, whereas in 9 out of the 12 patients, 12 non-responders actually had defect of interferon gamma signaling pathway genes. So when we extrapolated this data into the TCGA database of a total of 367 patients, we found 134 of them actually harbored interferon gamma pathway gene defect. So these patients actually survived significantly shorter. So it looks like tumor interferon gamma gene defect is not only a predictive biomarker for ipilimumab therapy, but also it's prognostic. So concurrently with, so when we knock down the interferon gamma receptor genes in the B16 tumor cell line and transfer them back to to mice, as you can tell, once we knock down the interferon gamma receptor 1 gene, these tumors actually don't respond to anti-CTLA-4 therapy very well anymore. So concurrent with our studies, a few other groups, including Tony Ribber's group, also found in patients treated with anti-PD-1, when they become resistant to therapy, they actually had acquired mutations in JAK1, JAK2, which are two key kinases of the interferon gamma signaling pathway. And a few other groups also did reverse studies, actually, to screen for resistance genes. It turned out some of them are actually interferon gamma pathway genes. So then we look at the tumor microenvironment. So to do that, we took advantage of a pre-surgical trial in prostate cancer. This again was conducted by Pam Sharma. So in this trial, 17 patients were treated with 2 doses of ipilimumab. After that, they had prostatectomy. So so we actually saw 0 pathologic response in these 17 patients. So we were very disappointed in the beginning. So we thought maybe this is because prostate cancer just doesn't have any immune cells in it. But when we look at the post-treatment tissues, we actually saw lots of immune cell infiltration, including CD4 T cells, CD8 T cells, memory T cells, and also CD68 positive macrophages. So we found these macrophages actually express quite a little bit of PD-L1 and lots of VISTA. And then when we further analyzed these macrophages, we found they actually manifest as more of M2 phenotype, which actually can inhibit T cell function in vitro. And when we pre-treated these macrophages with anti-VISTA antibodies, the suppression effect is actually gone. So in summary, you can tell there are multiple resistance mechanisms responsible for immune checkpoint therapy, including interferon gamma signaling pathway. Due to time limit, I cannot include all of them, but PTEN loss has also been shown to mediate resistance to anti-PD-1 and anti-CTLA-4 therapy, loss of beta-2 microglobulin, and also MHC1 molecule were all shown to be a resistance mechanism. So in the tumor microenvironment, as we show, increase of immune checkpoint inhibitors such as PD-L1 and VISTA can be a mechanism. Recently, TGF-beta has been shown to exclude T cells from tumors to mediate resistance to anti-PD-L1 therapy. So again, those are just a few examples. So I want to leave you guys on this slide so that we can discuss further about these resistance mechanisms and how to overcome resistance. So in the tumor microenvironment, as you can tell, apparently the first thing we can do to overcome resistance is to increase T cell infiltration. So we can use, TGF-beta blocker. We can, falsely increase T cell numbers by giving adoptive T cell transfer therapy. We can also choose to increase T cell function. The nectar-pegylated IL-2 agent is very promising. We can also combine one IO agent with others. We can also inhibit the inhibitor cells such as Treg, MDSCs. We can also increase the function of antigen-presenting cells, such as dendritic cells, such as tumor-associated macrophages. Of course, we can block other immune checkpoint agents, immune checkpoints by using such agents such as anti-VISTA, anti-PD-1, anti-LAG3. Of course, we can also target metabolism. So inside the tumors, apparently one mechanism for tumor to evade immune response is to not express very much tumor antigens. So apparently we can kill these tumor cells with TKIs in the setting of renal cell carcinoma, anti-VEGF. In bladder cancer, we can apparently try chemo. In any type of cancer, we can try radiation to increase tumor antigens. We can naturally select, some tumors with MSR high, which has more mutations or DNA damage repair defects. Uh, we can also increase tumor antigen presentation by using, by engaging tumors that's already on tumor cells, such as we can use the MAGE-based therapy. Again, we can use CAR T cells, or we can use chromosome remodeling agents such as DNMT1 inhibitor. So those we can increase, apparently can increase tumor antigen expression as well. We can change tumor phenotypes. As you know, EMT has been shown to make tumor evade immune response. So apparently we can use certain chemotherapy agents to change EMT phenotype. We can also overcome tumor genomic effects by, by doing in the setting of interferon gamma signaling, we can apparently use radiation, which has been shown to increase interferon gene expression, and also other agents like CpG DNA or Toll-like receptor 9 agonists. In the setting of PTEN loss, apparently we can use PI3 kinase inhibitor. So in bladder cancer, as you guys probably know, we can target FGFR3 mutation. So the phase 2 data using the erdafitinib is actually quite promising so far. Anyway, so I used quite some time. I will be very happy to answer any questions.
Were you surprised with the IDO inhibitor sort of initial failures, and do you think that'll carry forth throughout the field? There's a lot of excitement, and now there's less excitement.
So I think there is no more exciting time than now. Despite the fact these immune checkpoint mono agents actually just give us 20 to 25% response rate. It's a huge building block in cancer history. I think going forward, as long as we target the exact mechanisms, as long as we study patients and their tumors well, I think basically we can do two things in the future. One, if I see a patient, I will take out the tumor, do exome sequencing, figure out the genomic defects, and two, figure out the tumor immune microenvironment as well. So we should design trials based upon patients' tumors, based upon the tumor information, including genomics, and also the tumor immune microenvironment changes. So if we do that based upon tumor biology, instead of basing upon a drug, we have a better chance to succeed on that particular patient. So right now we are testing drugs. We are, we take, say, anti-Vista. We want to test on this patient. If there is toxicity, bingo, the drug is gone. If we are lucky, if we use something like anti-PD-1, we see a 25% of response. We declare this drug as a victory. So, except actually, 75% of patients actually failed. So I think we really need to do, going forward, we really need to do patient-oriented trials instead of drug-oriented trials. And we have the information at this age to do that.
Alicia?
Thank you. So I think we're all really excited a few years ago when we saw Julie's data, and I'm just wondering if anything that you found with your work, and those were beautiful studies, can anything that you found really relate back to what Julie found from enzalutamide? I think we're all still waiting to understand that mechanism, and I'm just curious.
That's actually not my field of study, but So Nizar and I actually team up to do quite a few studies together. So this one is not involved. So we actually conducted a neoadjuvant trial in bladder cancer with tremi durva. So far we have enrolled 15 patients on this trial. This is in patients who are ineligible for cisplatin-based therapy. So we have finished cystectomy on 10 patients, and we have seen a pathologic CR rate of 50% in 5 of them. So 7 patients actually had downstaging disease from T3, T4, T2, T3, T4 to T0, T1. So we see about 70% of the response rate. The other trial was done with Nizar, Pam Sharma, and a few other colleagues. So this is a combination trial with Nivo versus Nivo plus EP versus Nivo plus bevacizumab. So this is a pre-surgical trial in the metastatic setting. Similar to atezolizumab plus bevacizumab, we actually see a close to 60% of response rate in the Nivo plus Bev group. So what's amazing is in the patients who actually had, who completed cytoreductive surgery, including nephrectomy or metastasectomy, in that group of patients, we actually saw close to 90% of response rate, combined with surgery, of course. So that's something we just submitted to the ASCO meeting. So of course, this is all in the framework of IO combination. But in my lab, we are trying to combine certain chemo. We are searching for certain chemo that actually can modulate immune environment, which makes it easier for immunotherapy to work. So apparently, one person can only do a few fields of work.
So
thanks.
just a hopefully quick question, but we know there's a lot of tumor heterogeneity within a patient, genomic. What about the microenvironment? Has anybody ever looked at biopsying multiple different areas and finding, is a microenvironment the same? Because obviously if the microenvironment stays relatively the same in that patient, it's a much easier target than genomically when you may have multiple different clones throughout a body and trying to target that. Do you know?
Yeah, we actually, on this pre-surgical trial, renal pre-surgical trial, we were very fortunate to be able to take out some patients' kidneys, diseased kidneys for study. So even for those patients who have dramatic response, like within 8 weeks, you can still see different areas actually have different response. So in those patients who didn't respond, it's the same. I think this is probably caused by the interface between the tumor genomic heterogeneity and also the tumor immune microenvironment. And with more powerful imaging studies such as CyTOF, I think in the future we will answer your question more clearly. But I don't have any statistical data to show
how
that.
much there may be variability between areas.
Right. Yeah. So Nizar actually did some studies in RMC as well, and he saw similar patterns. So.
Okay, Jianjun, we have to move on, but thank you very much.